initial red flags. All right, you're in some sort of pain or discomfort you don't know. Triage to this list. Is it a 7 out of 10? I would say 7 out of 10 for most people is a good place to start. Are we above 7 out of 10? Yeah, let's call that a yellow flag. Is there radiation? Let's call that a yellow to red flag, right? So are there associated, and this is going to be tough for some people, but we're going to walk through this. Are there associated, motor or sensory deficits? Meaning, there's low back injuries that might make it difficult for you to lift your foot, right? It's a condition called drop foot associated with the sacral nerve issue. So if you have a hard time, like with in that case would be a motor dysfunction, other notable motor dysfunctions that may classify your condition as painful and not just discomfort. Oh, I don't know, like losing control of your bowels and or bladder, that would be a problem.
That's a big one.
That's a big one. So those are a few that come to mind. And that's just in the acute phase. I think it's also worth having a conversation as low back pain being so persistent, so prevalent, that one of the easy ways I think to differentiate pain from discomfort is through time, right? So, there may be something that in the short term with, when something hurts, and I've had this happen time and again, and I've always found myself wondering, or I have found myself wondering, is this pain or discomfort? Is what happens in 24 hours? Where are we at in 72 hours? Where are we at in, I would go about as far as a week. If we hit a week, and that would be on the outer limits of where I think you should be, I think somewhere between 72 hours and a week, if you are still undergoing the consistent perception that may be pain that checks some of these prior boxes, you might want to, go seek some sort of care alternative to just your own management. And as I think that's really useful. I've had injuries or I've had perceptions that in the first 24 hours I think I'm fucked. Like I think I'm headed for the surgery table. And even me who's dealt with these issues professionally for a decade now, when it happens to yourself, it's always different. And so, but I think time is a really useful metric to parse out whether or not we're dealing with pain or whether or not we're dealing with discomfort. Because it may be that in the first 24 hours, like you're going through it and then it settles in. But there's also cases, and this is where time I think is particularly useful. There might be cases where in the first 24 hours you feel fine, right? And then over the course of days 3 and 4, you start to regress, or what likely happened, you start to express the perception that is no longer being masked by other systems that might be guarding you from that pain, right? So a car accident is a really common example of this, where, the first couple of days, you might still be running some sympathetic operating system that's shielding you. So just to recap quickly, step number 1, when triaging and troubleshooting low back pain, is first understanding the criteria of whether or not you are in pain or discomfort. Some red flags that might indicate to pain: 7 out of 10 perception of pain fairly consistently. Dealing with any sort of nerve-related issues, whether it be lack of sensation, skin, touch, heat, whatever, and a lack of motor output, right? If you have a motor deficit, can't move a particular part of your appendages or what have you, that too is going to be a problem. Then when we get into the timeline, if you have something that feels painful in the short term, give it a few days and see where things sort of percolate down to. But vice versa, even if you feel what may be something that is presenting as discomfort, would too give it a few days to see whether or not that discomfort is true to form, whether or not you're dealing with discomfort as some residual from some masked issue that's much larger than that. So I think, out of the gate in managing low back pain, understanding whether or not you're in pain is, I think, a logical first step.
Yeah. I think kind of to pair with that also is if we can start to understand, and this is getting towards intervention, but the things that make it feel better and the things that make it feel worse, right? Palliative versus provocative towards the pain. So there are going to be certain ranges of motion that may have no effect on what you're feeling. There may be some that increase pain and do so in a way that, again, is not going to have an advantageous outcome if we continue to move through those. So that can be a starting point when you're starting to sort through, okay, I have this issue. I've determined that it is low back pain. There is some sort of injury present. It's something I'm going to need to work around in terms of building back strength, coordination, awareness, to getting back to doing the things that I want to do. A really easy way to start that process is understanding the things that either have no effect on the issue, or the things that make it feel better. And those are going to be things that you can kind of put into a bucket of, okay, these are things that are tolerated well. We can continue to do these things, and it probably won't have much of an effect on the issue, or it will have that palliative effect on the injury that we're having. Is that these are things that are going to make it feel better. They're going to relieve the muscle tension. They're going to allow me to move with more freedom and less pain. That's a really valuable understanding to have, because that's going to be essentially what makes up the beginning of your rehab protocol, is doing the things that make it feel better or don't affect the issue. And that's how you actually rehab pain. It's not just resting until 6-8 weeks and then trying to do the same shit you've always been doing. Because if this injury happened in the gym, that means that something has to change. It means that what you've always been doing is the thing that caused the injury. It caused the issue. So there needs to be some sort of change there. So if you can interpret the things that make it feel better or don't affect it, those are the things that you want to start with. And the things that make it feel worse, those I put into a bucket of, I kind of categorize them as, okay, is this something that we're unsure about? Like, it doesn't feel good, but it doesn't feel bad. Okay, that's great to know. Or is this something that it feels really bad and we're not going to do this? And then once we can kind of rank those things to the things that are more tolerable to the things that are less tolerable, then that's going to kind of dictate the order in which they're going to come back into that exercise progression. Is that we can take that first thing in line, the thing that it doesn't really make it feel better. It's definitely not no effect, but it doesn't make it feel terrible. Then that's going to be something that, after we have a period of time where we're doing things that are palliative to the issue and don't affect the issue, we can bring this back in and we can test against that. Is that once we have a subjective understanding of, okay, this felt not great last time I did it, but now I've been doing these things for a while that make it feel better. So I'm going to test this again. It actually feels better. Then that's going to be a subjective sign of progression, that whatever the issue is getting better. So I can tolerate things that I could not tolerate or were not well tolerated before. So building that understanding and kind of ranking those things is a really important part of the assessment process, because it actually gives you a starting point. It gives you a place where, all right, I have an understanding of the bounds on this pain, the ranges of motion or the specific movements or loading parameters that I can do and the ones that I can't do. So I have a starting point. I don't have to just rest and do nothing for a while before I start to get back in the gym. And honestly, for low back pain, because low back pain can be pretty gnarly, this could just mean that you're doing externally supported upper body movements for 4 to 6 weeks until whatever that injury is, no matter how acute it is, starts to calm down. And if tissues need to heal, then you're starting to get some tissue tolerance back. Then it could put you in a place where maybe you're starting out not doing anything for the lower body to allow that to heal, and just doing things that aren't going to require much core activation or core bracing in a time period where you actually need to heal. Because that is a part of this, as I kind of started off, is that there's things that are going to be categorized as low back pain that are not due to tissue damage, and there's going to be things that are low back pain that are due to tissue damage. So if it is tissue damage, then there might be a very real consequence in terms of healing time before you can start to load those tissues again and do so in a way that's going to be productive in the overall grand scheme of getting things to feel better. So understanding those two sides of it is what makes it feel better, what makes it feel worse, and then slowly starting to dose in those things in a progressive way where you're getting an understanding of what feels bad and then how you can test against those over time.
Yeah, I think the inventory of intolerances is really useful. And it may be difficult for some to know exactly. And I think it's really, it's good to impart some clinical wisdom on people and be like, okay, there are going to be three planes that we're primarily concerned about. You have hurt your back. Maybe it's pain, maybe it's discomfort. Can you, standing or seated, bend forward without pain? Can you standing or seated extend backwards without pain?
Yeah.
That is likely, more often than not, one is going to be painful and the other is going to either be null or palliative. There are some cases where both are painful, and that could make life a little bit difficult. The second is going to be lateral flexion. Can I side bend to the left? Can I side bend to the right? Are one of these palliative? Are one of these painful? And then lastly is going to be rotation, standing or seated. Can you twist more or less your spine one way or another? It's useful to categorize your pain that way and be very specific about the planes and sides you you can move through versus the planes and sides you can't, because that will help inform exercise selection moving towards that intervention. And I think one thing while we're in the process of appraisal and assessment is, and I know we've sort of set out and said, hey, look, this is the beginner, but as we transition now into exercise prescription, as the tolerances and intolerances are going to really help be our guide in the initial planes of movement and exercise selection that come with it, is you need to understand your strength going into the injury. Like, how strong are you going into the injury? Because the one thing that you'll find, and we find this in ourselves and others, is the thing that will accelerate someone's rehab time or recovery time for an injury of all sorts is going to be the baseline strength to which that injury occurred. The stronger you are, the quicker you will recover, period.
Yeah.
So it's hilarious to me to see, and it's not funny, but I don't know. I find it funny that in the avoidance of injuries, people, one, you can't ever avoid injuries, so just don't try, but at least do the thing that will help you recover the fastest. If I had to pick one physical attribute to get myself out of pain quickly, what I'm picking is a very high baseline of strength going into the injury, right? So as the podcast world gets a hold of fitness and old people start to really pollute the idea of strength training and resistance training, hypertrophy, rehab, injuries, and all that, they so often take away people's best tool to fight the thing that's inevitably going to happen anyways, right? So, if you're afraid of injuries, wrap yourself in bubble paper and stay the fuck at home and don't do anything for your life until you die. If you have a slightly more testicular fortitude and you decide to do something, understand that one, resistance training is inherently safe, and it is going to be the safest way for you to be able to acquire this one skill or tool that you can bring off the shelf to help you rehab any injury faster. So rather than undertraining yourself and trying to avoid injuries, the more strength you can acquire, you're actually arming yourself with the known best antidote to the thing that's inevitable anyways. So that's a key component to this whole process is, one, don't let it deter you, but two, try and accelerate the strength process as quickly as you can to not avoid injury, because that's impossible, but you want to aim your trajectory and your training towards getting as strong as possible, because that'll be the thing that pulls you out of any tailspin the fastest.